Now we're going to hear Holger Till about do we violate the Hippocratic Oath when we innovate?
Yeah, so we have to fight the wolf. Thanks, David. Nice example. Yeah, do we violate the Hippocratic Oath when we innovate is my talk. As we've heard in 3 brilliant talks, and as we all know who have been coming to IPAC year after year, our medical profession wouldn't be the same without this meeting, without the innovations, without the innovative guys and girls that are sitting in the room. They are critical to the advancements of our specialty. And good clinicians as you are, you constantly adapt and modify your clinical practice to offer the best possible care. And here we come to Hippocrates. He swore by Apollo, the physician, and Asclepius, the surgeon, with regard to healing the sick, I will devise and order for them the best. Surgical treatment he couldn't say, he meant diet, according to my judgment and means. And I will take care that they suffer no hurt or damage. That famous sentence, then translated into probably every language, do no harm, nil nocere suprema lex, and many, many others, summarizes this Hippocratic Oath. The best treatment. The physician's oath, just to be ethical, is defined by the Declaration of Geneva, which has many amendments, the latest in 2006, and it basically states the same. For you as physicians, the health of my patient will be my first consideration, and I will practice my profession with conscience and dignity in the best possible way. So actually, everything we heard so far, we could summarize and say, fine. But 3 talks before already mentioned, what about those innovative practices that will not be the best treatment? What do you do? How do you detect them? What are the real ethics about this innovative practice? The introduction of innovative practices means that you just do it. Some of you will leave this conference and will do it. Some of you have been to this conference and have done it and believed in what you've heard here. But innovative practice, unlike research, where you formally test in an animal model and then you go through another animal model and then you generate data and you accept these data, innovative practice by just doing and coping a technique that you've heard about it really is not directed specifically toward the production of generalized knowledge, but it bypasses it. And the LASCA Forum in 2003, that is a non-professional ethical organization, understood that by bypassing research, you may provoke, support false developments. And the LASCA Forum in 2003, on the ethical challenges of biomedical research and practice, proposed that clinicians' innovations involving a significant departure, esophageal atresia, for example, from the standard impose particular ethical concerns and require specific professional duties. And I'll present 3 problems, very simple. Inappropriate introduction, we heard examples. Premature adoption, we saw some data from Sean, and patient protection in terms of patient consent. What is, again, inappropriate introduction? Well, that you introduce a technique and it's not a good one. An inappropriate introduction of an inappropriate practice, which is not effective and which is not subject to a formal study, may be misleading to you and your patients. Incurs increased morbidity, unnecessary costs, and violates the patient's rights. Why may that happen? Conflict of interest. You may expect a boost in your academic career or have a personal interest. Financially, it may be. Our profession needs some strategy against it, and these are the duties to us here, today, and next year. To detect inappropriate introductions, we have to structure the process of innovation, so to learn from it. Basically, that means when you do something new, you need a protocol in the chart of your patient. And when you do a couple of cases, you openly, transparently, and honestly need to share what you've learned here with us. And if it's an inappropriate introduction, let us know. We have many examples of appropriate introductions just to stress the value of IPAC and what we've accomplished in the last 15, 18 years. The best example, I guess, familiar to all of you, the introduction of thoracoscopic TEF repair. Good example yesterday when Steve moderated the session, he asked how many of you are doing it. I think at least 2/3 in the room raised their hand, and he was proud. He was one of the founders of the technique in 1999 with Tom Loeb in Berlin. He then in 2000 already in Atlanta showed the first TEF case, always transparent with the data, always communicating with us, with people. In 2002, then 15 centers already performing it. So as Whitholcomb, Sika-Young and others got together to study those 104 patients, published it, we could rely on the data, then further progress, and it went to the fellows, it went to the residents, and many, many, many people are doing it now. So appropriate introduction. Premature adoption. Sean gave a good example. We missed that in some places to prove that what we are doing is actually right. We just adopted it. What is premature adoption? Well, when an innovative practice is introduced and it becomes just common sense because you believe in the people who are doing it or you believe on anecdotal reports. But premature adoption of innovative practice without the formal scientific testing may compromise your ability to determine the risks and the benefits. And, which is even worse, and which happened to IPAC, which happened to SAGES, once it has become common sense, it is increasingly difficult to recruit patients, let's say open versus laparoscopic cholecystectomy. Impossible to do, has never been done in a retrospective way, maybe, but not in a prospective randomized control trial. You would not recruit anybody at this time for an open cholecystectomy. So the duties to the profession, careful. We have to detect those innovations that we send back to research to say, well, maybe, but put a hold on it, stop this for a moment, because we all get to think it is good, but it may not be, and test it. Here's another good example of IPAC. Some of you may remember that in 2003, 4, 5, in the time when I was in Hong Kong, we did laparoscopic Kasai operation. Technically, honestly, no problem. Open as good as laparoscopically. Kenneth and all know. So there were many centers who technically were able to do it the right way and do it exactly as in the open way, and still the patients, when it comes to one single parameter, disease-free survival without liver transplantation, finally we recognized not as good. There must be something going on besides the technical point, the finesse of operating. So there was a consensus of Professor Esteves, CK, Klaas Baks, Benno in the room, Steve Rothenberger said, let's put this on hold for a while clinically and send it back to research. Clever guy like Paolo put it on back into a murine model, tested it and said, well, there may be a problem, not technically, but biologically, maybe laparoscopy is a problem by itself, either by damaging the liver or by increased pressure in the abdominal cavity. That is still ongoing debate. I don't want to go into that. I just want to let you know that scientific testing may be, at a certain point, the answer to premature adoption. And finally, coming back to David, patient protection. Your patient must know when you start a new technique the plausible risks. You may not calculate them, you may not give percentages, but you must have a gross idea. In addition, the patient wants to understand your personal, very important. The duties to the profession, you must disclose the purpose and the benefits and the risk. We've had a nice setting yesterday about the skills level of everybody here in the room. If you think it should be done, if you think the technique is sexy and you want to do it, but your skills level do not reach that level, don't just do it, but get connected. And finally, the practitioner has an obligation to protect the patient from potential harms that are not appropriate, so there must be a stop within the operation or a stop in the development. And with that, ladies and gentlemen, I close the ethics by saying the introduction of innovation, practice, and technique is essential to our medical progress, to this society. And without an adequate evidence-based practitioners, which we probably never will have, there are 4 basic considerations which you should do. 1, get approval from your local ethics committee. 2, disclose, as I mentioned, to get a patient and guardian informed consent. 3, monitor the results, as I mentioned, and do this honestly and openly. Finally, if the technique is not as good as you think, stop it and then design formal research to test the advantages and the disadvantages. And finally, come back to IPIC and share your experience so that we will continue to be like the School of Raphael, very intelligent people sitting together, joining our interests and discussing nice techniques in the future. Thank you very much.
Thank you, Holger. Fantastic talk. We have 10 minutes for discussion, so it's open.